Thank you. So actually, today I thought we will have this more as a discussion, but we will just start with some clinical case scenarios and then go on to the influenza virus. As you know, I think over the last maybe 1 year, we have been seeing, although, as you know, this influenza comes in, it's called a seasonal flu in other countries. We have actually in Sri Lanka not been very concerned about influenza up to about few years back. And I think when I was training influenza, we didn't even consider it as a diagnosis, I think, at that time. But now I think we are seeing more and more cases and more bad cases coming in. So and of course, the ministry also has issued guidelines way back in 2015 for management of influenza. And over the last 1 year, I think probably all the physicians here would have encountered, we are seeing lots of viral infections. And people just say flu, viral infection. And of course, because we don't do the diagnostics, we are not exactly sure what they have got. Of the viral infections, which are quite common over the last 1 year, I think influenza plays an important role, especially in the severe pneumonias and severe illness groups, as well as, of course, over the last few months, we have had a few cases of COVID, sometimes causing major problems, and other viruses, RSV, and I think Atheeka will talk about them, which have been worldwide, actually. Over the last few months, there has been several outbreaks in several countries, and I think it has been diagnosed in Sri Lanka as well. So there have been several patterns of these viral infections over the last few months, maybe 1 year now, actually. And although it is called seasonal influenza, and what is usually said that it is during the rainy months, during the monsoon months, but we have been seeing this now. Maybe our rain patterns have changed and our weather has changed, so that we are seeing this sort of on a daily basis without any seasonal variation as well. So I think management of these patients is vital. And of course, in addition, important aspect from the viruses, the influenza, what is important is we have prophylaxis. So how we can do the prophylaxis properly, although it's not in the national EPI, we need to be very concerned about this, and because it's available in the country for specific targeted groups. As you know, in other countries, it is widely used over so many years, but we need to give it every year. So as the virus changes, which will be discussed. So therefore, I think just update on influenza at the moment. Also, just a few months back, we have been having so many cases of influenza, some bad cases, many mild cases. So how to manage them is important. So I would like to call Dr. Nirasha Jayathilaka to give us a clinical update, clinical scenario of what type of cases we get and sort of the clinical management. Over to you, Nirasha.
Thank you, sir. Good morning. First of all, I would like to thank the Kandy Society of Medicine and Dr. Manil Peiris for giving me this opportunity. Over the next 20 to 30 minutes, I'll walk you through the clinical presentation and WHO definitions of influenza and clinical management, as well as antiviral therapy, according to the latest guideline published by the WHO in 2024. First, we'll start with some case scenarios. Case number 1, we have Mr. A, 35-year-old gentleman, presented with 3-day history of fever, muscle aches and fatigue, and also he had sore throat, nasal congestion, dry cough, which started 24 hours after his fever began. He did not have any breathlessness, chest pain, or wheezing. He did not have any previous medical conditions. He's a non-smoker and office worker. He had few colleagues in his office who had similar symptoms over the past week. On examination, he was febrile with a temperature of 38 centigrade. His pharynx was erythematous, but no tonsil exudates and no cervical adenopathy. Respiratory system examination was normal, lungs were clear. Cardiovascular examination and the abdomen was normal. So what could this be? This can be anything like common cold, secondary to common viruses, rhinovirus, RSV, adeno, etc. This could be influenza, COVID-19, or early onset of bacterial respiratory tract infection. So his source of influenza A was positive. Full blood count showed mild leukopenia, otherwise normal. Chest X-ray was not performed because he did not have respiratory distress or features suggestive of pneumonia. So how was the patient managed? It was basically symptomatic management with as needed paracetamol, hydration, and rest. Antiviral therapy was not recommended even if the influenza A was positive because he had mild disease. Reassurance and education on signs of worsening symptoms, including difficulty in breathing, persistent high fever, was given, and to seek further care in case of any complications. The second case, this is Mrs. B, 65-year-old lady, presented with a 5-day history of worsening shortness of breath, high fever, and persistent cough. Her past medical history was complicated with COPD Gold B, Group E, hypertension, which is well controlled, type 2 diabetes with HbA1c of 7.2%, and she was obese with the BMI of 32. She was on metformin, losartan, and inhalers for her COPD. She's a retired teacher, and again, she had a family member who had bad cold over the previous week. On examination, she looked ill, febrile, and her mucous membranes were dry, and she had nasal congestion. She was dyspneic with a respiratory rate of 28 breaths per minute, and her saturation was 87% on room air. She had bilateral clefts in the lung bases with intermittent occasional wheezing. She had tachycardia with rate of 105 beats per minute on admission. Blood pressure was 140/85. Other examination was normal. What could this be? This can be community-acquired pneumonia. This can be influenza. She had a contact history, although it is not confirmed. This can be COPD exacerbation triggered by another viral upper respiratory tract infection, or this can even be COVID pneumonia. Again, she had contact history of a patient with respiratory with a bad cold. For her, again, the influenza throat swab was positive for influenza A, COVID antigen negative. Her blood gas showed respiratory acidosis with acute on chronic type 2 respiratory failure, and inflammatory markers were high with WBC of 13,000 and CRP of 104. Lactate was little high, and blood and sputum cultures were negative. This is her chest X-ray, which shows bilateral, lower, and mid-zonal ground glass opacities. So basically, she required oxygen therapy to maintain saturation, target saturation of 88 to 92%. She required NIV because she had respiratory acidosis, and it was continued until correction of acidosis and weaned off. She had positive influenza A with features of severe disease, so she was given Tamiflu, oseltamivir for 75 mg BD for 5 days. And with high inflammatory markers, she was given empiric antibiotics with ceftriaxone and azithromycin, COPD management with bronchodilators and inhalers, and hydration and monitoring. So the outcome, she was recovered and discharged. So in 2024 September, the WHO has issued a new updated clinical guideline for management of influenza. According to this, they have defined the disease severity of influenza. So what is non-severe influenza? If the patient has uncomplicated non-severe influenza illness, which is characterized by sudden onset cough, headache, muscle and joint pain, severe malaise, sore throat, rhinorrhea with or without fever. Most of these people will recover without requiring medical attention, usually within 1 week. The non-severe influenza is defined as absence of any criteria for severe disease. So what is severe influenza? Basically, this is severe illness causing complications such as sepsis, septic shock, severe pneumonia, ARDS, multi-organ failure, exacerbation of chronic medical conditions or death. These patients require hospitalization and in severe cases, HDU, ICU care as needed. How do we identify patients with non-severe influenza but at high risk of hospitalization? Basically, the patients with higher risk they have defined patients more than 65 years or more, immunocompromising conditions, if they have cardiovascular disease, neurological disease, or chronic respiratory diseases. Further, the patient with malignancy, pregnancy, and diabetes also have higher risk, but less than the above mentioned types of patients. Who are the patients at extremely high risk of hospitalization? This is defined by age more than 85 years or more, any age of patients with multiple major risk factors, which I mentioned above. So what is the mortality? For non-severe influenza illness, the mortality is 1 per 1,000 patients. For severe disease, this is 30 per 1,000 patients. How do we manage patients with influenza? Basically, all the patients need supportive and symptomatic care. The most important thing is identifying patients either with severe disease or patients at high risk of developing severe disease. For severe infection, they need antiviral treatment. Neuraminidase inhibitors are the widely available and active against all circulating influenza viruses. Of the 4 neuraminidase inhibitors which are commercially available, Tamiflu or oseltamivir is the most widely studied and available. So what are the recommendations for patients with non-severe influenza according to the latest guideline? It recommends against the use of all neuraminidase inhibitors, including oseltamivir, and antibiotics for patients with non-severe influenza. The only exception is that there is a conditional recommendation for the use of baloxavir for patients with non-severe influenza and at high risk of progression to severe disease. Baloxavir is a liver antiviral with a different mechanism of action than neuraminidase inhibitor. That is a selective inhibitor of influenza cap-dependent endonuclease. So the recommendations for severe influenza, it recommends for the use of oseltamivir for patients with severe influenza, but against the other antivirals, particularly this is due to the lack of quality evidence. So regarding the baloxavir, I don't think it is not available in the Sri Lanka. We have only the oseltamivir. Baloxavir is an oral drug. It has a long pharmacokinetic half-life, so it is given as a single dose according to the weight. And this is how we give oseltamivir for adults more than 40 kilograms. We give 75 milligrams of Tamiflu for 5 days. And for children, it is according to the weight. The duration, usually it is 5 days, but always you can decide that depending on the patient's clinical condition, you can extend this up to 10 days. So this is the oseltamivir dosing in patients with renal impairment. If the creatinine clearance is less than 60, we have to always go for dose adjustments. So what are the new recommendations for adjunctive treatment for patients with severe influenza? The WHO recommends against the use of macrolides as an immunomodulatory therapy for severe influenza. But if you have suspicion or confirmed evidence that the patient has bacterial co-infection, you can give macrolide for that purpose. The other adjunctive therapy is the corticosteroids. The WHO recommends against the use of corticosteroids. So simply for severe influenza, they do not recommend using corticosteroids. But the exception is that if the patient has overlapping ARDS, then you can consider. So what are the recommendations for prevention following exposure to seasonal influenza virus, but without infection? So it recommends for the use of baloxavir for asymptomatic persons who are at extremely high risk of hospitalization if they develop the seasonal influenza. And also it recommends using oseltamivir for the same category. So if you remember, the extremely high risk group is that the patients over 85 years of age and of patients with any age with multiple risk factors. So in that scenario, you can think of giving post-exposure antiviral treatment. Mind you that antiviral post-exposure prophylaxis does not replace influenza vaccination. So this is how we should give the post-exposure prophylaxis. That is a half dose of the treatment dose, but for 10 days. So for adults, more than 40 kilos, it's 75 milligrams daily for 10 days. And for children, according to the weight. Okay, so the latest, the available local clinical guideline on Tamiflu in Sri Lanka is published in 2015 September. By that time, we had a lot of limitations. The testing was done only in the MRI, and Tamiflu was not that available, and we had to admit all the patients throughout the 5 days to give Tamiflu, and it was not available in the private sector. But now, the testing is widely available, and oseltamivir is available, including in the private sector. However, the resistance to antiviral medicines, if it develops, is a serious problem. So always you have to think, am I giving the right drug to the right patient? This is to prevent antiviral resistance. So my main reference was the clinical practice guideline for influenza published in 2024 September by the WHO. That is the end of my presentation. I would like to hand this over to Dr. Atheeka for the continuation of this session. Thank you.
So, overview of my presentation, why we need etiological diagnosis for viral respiratory infections, what are the tests available to diagnose viral etiology, and collection of samples for diagnosis, and the influenza virology and vaccination. Why we need etiological diagnosis for viral respiratory infections? One is this targeted treatment to give the appropriate antiviral treatment, and for the infection control purposes, that is isolation and containment to prevent spread, and for the public health surveillance, that is for epidemiological tracking and seasonal trends to prepare vaccines, example, flu vaccines, and for the avoiding misdiagnosis, distinguishing from bacterial infection and differentiating other respiratory illnesses, and for the patient prognosis and monitoring, that is to predict severity prediction and follow up for complications. What are the tests available to diagnose viral etiology? First, we discuss about the antigen-based methods. These tests detect viral proteins rather than viral and genetic material, providing rapid results. We all know regarding the rat that during the COVID period, that this is rapid antigen test we can use for the influenza, which detects viral antigens in respiratory samples using lateral flow assays, similar to pregnancy test, and that commonly used for detecting virus like influenza and SARS-CoV-2. The advantages are this can produce fast results around 15 to 30 minutes, and simple and can be performed as a point of care test, and it is inexpensive. The limitations are less sensitive than the molecular test, especially in asymptomatic or very early or late infections. This test best used in cases with high viral load. The other second method of test is molecular methods. This detect viral genetic material, RNA or DNA. The most widely used method is this category, the real-time PCR. This method amplifies and detects the viral RNA or DNA, and it is considered the gold standard for diagnostic many respiratory viruses, commonly used for detecting viruses like SARS-CoV-2, influenza, RSV, rhino, adeno, and parainfluenza. We can use this. And the advantages are highly sensitive and specific, and detects low levels of viral RNA and can provide results in few hours. Limitations are this requires specialized equipment and laboratory facility and trained personnel, and this is relatively expensive. The other test is serological methods, but we are not much using for the respiratory viral detection, but we can use for detect antibodies produced by the immune system, which detects IgM, IgG, useful for detecting past infections like COVID-19, and which this cannot detect an active infections earlier. The following are mandatory for correct laboratory diagnosis and clinical interpretation. First is the properly collected sample, appropriate time of infection, and properly labeled appropriate container, appropriate transport conditions, and accompanying detailed request form. What are the samples for diagnosis? Samples from upper and lower respiratory tract. The choice of sample depends on the virus being tested, the severity of the infection, and the patient's condition. Upper respiratory samples for the early initial stage of infection, that is nasopharyngeal or oropharyngeal swabs, and the nasopharyngeal aspirates in children. We can test these samples for influenza, RSV, COVID-19, adeno, and rhino. The lower respiratory samples, sputum, bile, or ET secretions in the late stage of infection or in the severe pneumonia. Blood we use for the primary use to assess immune response like COVID-19 diagnosis, NISI. The nasopharyngeal swab and nasopharyngeal aspirate. I would like to tell that nasopharyngeal swabs, we have to feel that resistant when we collecting the samples to have a proper sample. The transport, store, and storage of samples. After collection, samples should be stored in an appropriate condition, usually in 2 to 8, and transported to the laboratory as quickly as possible. If we are getting samples from our hospital, that's okay to in a 1 hour to transport, because delaying transport will lose the quality of sample as well as the degrade the nucleic acid. Viral samples are typically placed in viral transport media to preserve the virus until testing, and delays in transport can reduce the sensitivity of the test, so timely processing is essential. And also, if you are getting delayed to send the sample, it's better to store in the refrigerator 2 to 8. And the infection control consideration, we have to consider that sample collection can generate aerosols. So particularly with procedures like nasopharyngeal aspirates or BAL, the healthcare personnel should follow proper infection control guidelines. That is, we have to wear PPE and ensure that the collection area is well ventilated. Now we will move on to influenza. Influenza, there are around 1 billion cases of seasonal influenza annually, including 3 to 5 million cases of severe illness. It causes 290,000 to 650,000 respiratory deaths annually. 99% of deaths in children under 5 years of age with influenza-related lower respiratory infections are in developing countries. Symptoms begin 1 to 4 days after infection and usually last around a week. A bit of virology. This is the anatomy of the viral. This is the nucleic acid material RNA, and there's a lipid envelope, and the hemagglutinin and the neuraminidase. So these are the also mix of viridae family, enveloped virus, single-stranded RNA. There's hemagglutinin and neuraminidase are critical for virulence, major targets for neutralizing antibodies. The hemagglutinin binds to respiratory epithelial cells, allowing cellular infection. And the neuraminidase cleaves the bond that holds newly replicated virions to cell surface, permitting infection to spread. There's a term called antigenic drift, alter the virulence in strains that by the point mutations, and antigenic shift, 2 strains reassorted in mixing vessel, producing a chimeric virus with H and N change, which can cause pandemics. These are the types of influenza viruses. There are 4 types: influenza A, B, C, and D. Influenza A is the influenza AH1 in pandemic 9 and the AH3N2. Influenza B, these 2 A and B are mostly circulating as seasonal influenza in humans, and the C rarely in humans. There are cases reported, and the influenza D in cattle. Little bit about transmission and pathophysiology. Transmission occurs primarily through respiratory droplets, but aerosol and surface transmission are possible. Pathophysiology involves viral replication in respiratory epithelial cells, then immune activation and potential systemic inflammation. Influenza can cause mild to severe illness with a risk of complications higher in vulnerable population. The complicated, there are 2 types, uncomplicated and complicated. Uncomplicated with high fever, chills, malaise, and myalgia, headache. The complicated can present as pulmonary manifestations, primary viral pneumonia, secondary bacterial, or mixed. In non-pulmonary manifestations, myositis, cardiac manifestations like myocarditis and pericarditis, toxic shock syndrome, and CNS manifestations like GBS. Treatment, antivirals are available. Antiviral treatment is most effective when started within the first 48 hours of symptom onset, but it can still benefit patients with severe or complicated influenza, that is in hospitalized patients, or those at high risk of complications, elderly, young children, pregnant women, and individuals with chronic medical condition and immunosuppressed. This is antivirals and mechanism of action. There are several types. The main are the neuraminidase inhibitors, oseltamivir. We all know that we mentioned as Tamiflu. This is oral formulation, and the zenamivir is inhalation. The peramivir is IV formulation. This inhibits the release of newly formed viral particles. The polymerase acidic endonuclease inhibitor, that is baloxavir, new form of antiviral drugs that inhibits the RNA synthesis of the virus. So there is another form, RNA-dependent RNA polymerase inhibitor. This is favipiravir. This is called as Avigan, but this is not used widely, but that is approved in Japan against influenza strains resistant to available antivirus. It's the mechanism of that's done. A little bit of antiviral resistance. The available data up to now shows high susceptibility rates of oseltamivir for influenza A and B. The high level of resistance to adamantines, that is amantadine and rimantadine, persist among the influenza A viruses. Adamantines are not effective against influenza B virus. We are not using that now. So the emergence of antiviral resistance is a major concern. Some more definitions about influenza. That animal influenza viruses circulate in animals, that is avian and swine influenza viruses. The zoonotic influenza means an animal influenza virus that causes species to humans. And the pandemic influenza, which is an animal influenza virus that begins to spread among humans who have no or little natural immunity. And the seasonal influenza, which is an influenza virus that has adapted to humans, causing seasonal epidemics, that is influenza A and B, which is the virus we are encountering our day-to-day practice. It's the human influenza, seasonal influenza A and B, that there are subtypes, and in B, they are we call as lineages, B Victoria and B Yamagata. There are clades and subclades. This is a little bit of our data. Influenza 24 RT-PCR data in our laboratory. In 2024, we have performed up to now, October mid, we have performed 729 samples for the RT-PCR. We did have reagents in early January and February. So from March onwards, we could continue our diagnostic testing facility. We tested all the requests we received for testing for influenza. So from that, the increasing trend was observed from May onwards, that we have tested 60 samples and total positives were 16, that is 26.6%. And from June, that percentage also continued, and up to now, that is the similar positive percentages observed. That October mid, we have tested until now 48 samples and 13 positives with 27% of positive rate. This is the influenza trend in 2017 to 24. In Sri Lanka, we usually see two peaks, like in April to June, like there's a peak, and October, November, there's a peak. In 2024, we have, I'm not into the August, September, October data. This peak is continuing now still, because that is around 27% up until October, like. Little bit about the pandemic influenza. There are several pandemic influenzas all of the last years. There were in 1889, there was a Russian influenza H2N2 pandemic, and 1900, there was old Hong Kong influenza H3N8. And we know about 1918 Spanish influenza pandemic, that was in 1918, which is H1N1, and 1957, Asian influenza H2N2 pandemic, and 1968 Hong Kong influenza H3N2, and the 2009 pandemic influenza H1N1. This strain is now circulating as a seasonal influenza. We all worried about this zoonotic influenza these days reported as H5N1. So this avian influenza, this is globally from 2003 January 2024 July, 896 cases of human infection with H5N1 were reported from 24 countries. Of these, 463 were fatal. That is for the case fatal rate of 52%. In this year, since April 2024, US reported 27 human H5N1 cases. 9 were associated with poultry and 17 associated with infected dairy cows. All these were sporadic from animal to human. They had mostly mild symptoms, many with conjunctivitis, but not any human-to-human transmission reported yet. And the influenza vaccines. So the seasonal influenza vaccines are the most effective way to prevent influenza disease, with safe and effective vaccines available and used for more than 60 years. Commonly used influenza vaccines are injected, inactivated influenza vaccines, virus which goes in chicken eggs. These comes as trivalent. 3 strains included: influenza A H1N1 and the influenza A H3N2 and influenza B Victoria lineage. There's a quadrivalent also available, which is rarely. And the other types of influenza vaccines, that adjuvanted live attenuated vaccine, which has given as intranasal spray, and the recombinant influenza vaccine, which is egg-free. The annual vaccination, so needed due to changing virus strain, that is due to antigenic drift. Vaccine composition is updated annually based on WHO surveillance and recommendations. And who should get vaccinated? Everyone 6 months and older can get the vaccination. Especially important for healthcare workers, elderly, pregnant women, and individuals with chronic conditions like COPD, transplant recipients, and immunosuppressed. The annual epidemics of influenza typically occurs between October to March in Northern Hemisphere and the April to September in Southern Hemisphere. Northern Hemisphere vaccine given in countries like North America, Northern Africa, Middle East, and United Kingdom, etc. And the Southern Hemisphere vaccine given in South America, Western Africa, Tropical Asia, and Equatorial Asia. In Sri Lanka, we generally observe 2 peaks, that is from April to June and November to January. According to WHO recommendation, the first peak of the year is considered and we get the Southern Hemisphere vaccine prior to April. Northern Hemisphere vaccine can be taken 2 weeks prior to travel to Northern Hemisphere, which is available in October, November. Both vaccines are now available. Now it means both vaccines are available in Sri Lanka at the private sector, but not in the government sector. Thank you.